So with that, I'm going to go on to our first talk today, which is going to be by Dr. Alexandra Villaforte. Dr. Villaforte has been with us for quite a while, and we're very fortunate for that. She actually did a vasculitis fellowship here at Cleveland Clinic before returning to her original home in Brazil and setting up a vasculitis center there and helping many people before we had the good fortune of having her return here to Cleveland. Her primary focus continues to be in the clinical care of people with vasculitis. Her research is focused on a wide variety of different areas, including some seminal studies in GPA Wegener's and her current research in large vessel vasculitis. And she's going to be discussing with you all today about small vessel vasculitis, GPA and MPA. Dr. Villaforte. So this is slides. This is the laser pointer.
Well, good afternoon. Welcome, and I'm very happy to be here. Thanks for this kind invitation. It's my pleasure to share with you some ideas about these two diseases that I was put in charge to talk to you today. And I'll be happy to go over questions at the end. So I will be talking over the next 20 minutes about GPA, formerly known as Wegener's, and microscopic polyangiitis, MPA. Very quickly, so I can place those two diseases in the classification of vasculitis where they are, let's start, and it's going to overlap a little bit with what Dr. Langford just explained. So vasculitis, as you heard, is an inflammation of the blood vessel wall. And depending on what size of the blood vessel, there are different results and consequences that can arise from that. So if the vessel is very small, most of the time what we see is narrowing of the vessel or occlusion. And that results in a low blood flow and inadequate blood supply to a specific organ, which we call ischemia. So that's how that organ suffers. If the blood vessel is very large, such as the aorta, then different results can occur from that kind of inflammation. That vessel, especially the aorta, almost never occludes. It can get a little bit narrowed, but the blood supply is still good. But the vessel gets very weak, the blood vessel wall, and it can result in bleeding or in the formation of aneurysm, which is shown there in that picture as this enlargement here of the aorta. And it can result in dissection or rupture of that vessel, and it leads to serious complications. When we think about vasculitis, there are many different ways of classifying them, and that's because we don't have a perfect way of classifying the vasculitis. One of them that I want to approach today is how we classify them into primary and secondary. What that means is the primary vasculitis have unknown cause. We really don't know what causes them. We give them names based on in the past on the person who developed or described the disease for the first time, or what we understand how the inflammation occurs, such as how we call granulomatosis with polyangiitis. So it describes what we understand how the process of the disease occurs, but it doesn't mean we know the cause. So this is what defines primary vasculitis. The secondary vasculitis, on the other hand, are usually vasculitis that occur secondary to a process or a factor that we can either identify or understand. So examples of that are infections such as hepatitis C, use of medications that can trigger vasculitis almost like a side effect. Some type of cancers, though rarely, can result in vasculitis, can cause that, and some of the rheumatic disease can cause vasculitis, such as those listed here, lupus, Sjogren's, rheumatoid arthritis, and scleroderma. So these are situations when we understand that the vasculitis was caused by something else. As you can see there, GPA and MPA are listed under primary vasculitis, meaning that we don't know the cause of these two diseases. Now, they are predominantly small vessel vasculitis, GPA and MPA, and they're part of the group of diseases with formerly known as Sjogren's, EGPA, and renal limited vasculitis, which is a type of vasculitis that affects the kidneys only. So those are all vasculitis that have a predominant involvement of small vessel, but also involve medium vessels. And that's important to know because the clinical manifestations or the symptoms that someone might have depends on the size of the vessel and predominantly. So GPA and MPA, I'm going to talk a lot about both at the same time because they're very similar, and I'll point out what the differences are. And the treatment is also very similar. So in general, they are typically diseases that affect multiple organs or parts of the body. They usually not focus on just one organ. Most of the time, multiple organ systems are affected either at the same time or over progression of the disease. The disease can start very severe from onset and start all of a sudden overnight. Or in some other patients may start with very mild symptoms that take months to years to progress and gets worse slowly over time, which makes it more difficult to make the diagnosis. GPA is much more common than microscopic cholangitis and MPA, which is very rare. So most of the studies on medications have a larger number of patients with GPA, and we apply some of these results to MPA as well because it's so much rarer. A little bit of what the differences are between this disease. GPA frequently causes granulomas of the upper and lower respiratory tracts and other parts of the body as well. So it's a very typical type of inflammation that occurs in GPA that causes this so-called granulomas, which are sort of masses or cluster groups of cells together. If you can see here, these are examples of granulomas. They are round and they're multiple different cells that are lined in this formation. So this is a typical appearance of this type of inflammation that occurs in GPA and does not occur in MPA. So sometimes if we see that on the biopsy, it helps us, it gives us a clue about the diagnosis, whether it's one disease or another, because we don't see this kind of inflammation in MPA. So that's just the distinction based on biopsy. They both have a very wide range of manifestations since they can involve most of the organs in the body, and a very broad spectrum of severity. As an example, commonly affected organ is the kidney, but someone might have a normal kidney function, and we make a diagnosis the kidney is involved and we start treatment and the kidney function never changes. Someone else with the same disease, with the same organ involvement such as kidney, might be on dialysis, might be losing their kidney function very quickly. So there's a very broad spectrum of severity on the same disease and the same organ involvement. So it's very important to really be focused on each person separately, how the disease is affecting their body. Affected organs in MPA and GPA are very similar with one exception. So commonly both diseases affect the lungs, the kidneys, the peripheral nerves causing neuropathy, skin, joints and muscles causing joint pain and muscle pain. As you can see, there's a significant amount of overlap between the two diseases, but most importantly, the ears, sinuses, and noses, or all the ENT, are almost never seen in MPA. Some of the vasculitis experts actually consider that to be a point of distinction between those diseases. And if they ever affected MPA, it would be very mild. But that's an important distinction between the two diseases. Multiple organs can be affected with different kind of manifestations. So for example, in terms of upper respiratory tract, the nose, the sinus, ears, trachea causing subglottic stenosis can be affected. Not necessarily all these organs are affected in the same person, but one of them with different combinations. But usually, like I said before, you have at least 3 or more organ system involvement in the same person. But it can be any combination of that. In the kidneys, we have a typical type of inflammation that's called glomerulonephritis, which is the tiniest blood vessel in the body called the glomerulus. That's the filtration unit of the kidney. And that's the typical area affected in those two diseases. So these are not large vessels. The renal artery is a larger vessel and is usually not affected in those two diseases. Polyneuropathies are common. They're more common in MPA. Up to 60% of the patients can be affected with that. And the most common type is called mononeuritis multiplex. And all that means is that single different types of nerves are affected in different parts of the body, like legs and arms, in no symmetric way. So multiple different single nerves. The eye can be inflamed and affected in many different ways. The anterior portion of the eye or the back affecting the retina or the conjunctiva are affected in different people. So there's not a specific type of manifestation. And as well as in the skin, any kind of rash or skin lesions pretty much has been described with both diseases. It can range from a mild rash to purpura, those purpuric dots, urticaria, which is hives. It looks just like hives. Ulcers can be quite severe, or just painful subcutaneous nodules. hemorrhagic blisters, and livido, which is a lacy pattern of just purpuric rash. So the severity varies a lot, and treatment will vary depending on what kind of skin manifestations. True arthritis is not very common, which we expect there will be swelling of the joint. More commonly is joint pain and muscle pain, but arthritis can also be seen in both diseases. With MPA, again, just to point out that ENT is usually not affected on these patients, making a distinction between these two diseases when possible. But remember that some patients with GPA will not have ENT involvement. So that sometimes makes it very difficult to make a distinction. And sometimes we don't make a distinction. We may call them, they have small vessel vasculitis, systemic small vessel vasculitis, possible GPA, possible MPA, or even call sometimes ANC-associated vasculitis, since that blood test is commonly seen with these two diseases. Interesting, I mentioned before that granulomatous inflammation or the formation of granuloma is not seen in MPA. That means that certain manifestations are not seen with MPA, those that are related to granulomas. So as we can see nodules and masses in the lungs on GPA, but we almost never see that on MPA. We see either infiltrates or hemorrhage in the lungs, because these are usually dependent on formation of granulomas. And other parts of the body will also be different between these two diseases because they're dependent on what kind of inflammation. Just to give like an example on pretty much anywhere in the body can be affected in GPA, but when it comes to mass lesions that can occur in the brain, breast, prostate, and different organs, they're rare, but they don't happen usually in MPA because they're dependent on granuloma inflammation. An interesting fact here is how different the disease is over time. So when someone first presents that has initial symptoms, has never been treated, you might have a set of symptoms or organ involvement. But over time, as they are on treatment and they have relapses, this disease might be a little bit different when they relapse, and that is affected by treatment. So this is just an observation that I made on a group of patients over time years ago. And the upper way, these are all patients with GPA. At the time of diagnosis, this is the percentage in red bars, and the time of relapse is in black. So the interesting information here is that I noted that the lung and the kidneys were frequently affected at the time of diagnosis before any kind of treatment was started. But at the time of relapse, when most patients are on treatment, these manifestations were not so common. So even when we see relapses, if someone is on treatment, they tend to be much milder and not affect major organs. So even though they might occur, they're usually not necessarily as severe as the initial presentation of the disease. So that's an interesting observation that supports us continuation of treatment. So establishing the correct diagnosis is the first step on any kind of vasculitis, also in GPA and MPA. If we're correct, if we make the correct diagnosis, we're more likely to give the appropriate treatment and start out correctly. And avoids unnecessary use of these immunosuppressive medications in other diseases. So if we miss another diagnosis that is not vasculitis and we start immunosuppressive medications, it might be ineffective, it might give unnecessary toxicity to patients, may worsen the underlying disease, and there is a treatment delay until we get the right diagnosis. So we have to really take our time, especially in the office in the first visit. I might take a whole hour, we all do that here. Just getting a history, a very detailed history of how did the symptoms start, what kind of symptoms, and trying to understand that very well so we were more likely to make the correct diagnosis. So how do we go about making this diagnosis in GPA and MPA? First, we have to have a clinical suspicion. I'll talk a little bit about that. If we don't think vasculitis, we'll miss it because they're very rare diseases and they mimic a lot of other diseases. So we have to raise this clinical suspicion when we're listening to the history. We get a very detailed history with a good description of symptoms and how did they occur over time. We usually do a complete physical exam at every visit, but the initial visit mostly important, and we might find something that was not bothering someone they didn't complain about, so the physical exam is important. How many times we find maybe a small lesion in someone's elbow that they didn't notice, because who looks at their elbows is actually kind of hard. So the physical exam is very important. We do focused laboratory testing because there's no perfect laboratory test, so we have to be able to interpret the results in the setting of a constellation of symptoms. Imaging study is almost always necessary in GPA and MPA. Remember that very commonly the lungs are affected. In GPA in particular, they might not give any symptoms at all, so at the time of diagnosis, even if there are no respiratory symptoms, I tend to get a CAT scan of the lungs in all patients. We might find nodules or masses there, they're not giving any symptoms, and we would have missed that without imaging studies. Biopsy is very helpful when possible, not always accessible. If we don't have something to biopsy, we don't biopsy areas that are normal. So in the skin, you have to have lesions, but doing a biopsy of normal skin is not going to be helpful. It's going to come back normal. So that really depends on the clinical manifestations. So talking a little bit about clinical suspicion, we think about GPA or MPA as a possibility. The first initial suspicion is when there is a multi-system disease, meaning there are multiple organs involved. Then we start to think of the possibility. And those are the ones that I showed before. In our history and exam, what I'm hoping to do is to identify all and every symptom and organs affected by the disease since its onset. I try to understand how the disease started and progressed over time. How did it change? I try to establish how severe the disease is, both at the time of the onset of disease and at the time when I'm there seeing the patients. That's going to influence the treatment choice. I try to understand the past treatments because they might influence how severe the disease is at that point in time and what worked and what didn't work so that we understand what's more likely to work at that point in time. I try to understand if there is complications from the disease, what kind of complications and how they might have caused some kind of damage. And complications from treatment if someone has already had treatment. History of relapse are very important, especially in GPA. This is a disease that tends to relapse. And in someone who has had multiple relapses, we tend to believe they have a higher risk of having further relapse. So we're more careful on monitoring, on treating, and then be more alert. Just to give an example on how difficult this can be, when you think about ENT in GPA, it's one of the most challenged situations in an everyday life. It's frequently very difficult to distinguish damage from active disease. A lot of people, they have ongoing chronic symptoms that tend to never go away, and the disease seems to be in remission. So when we look at the nose and we try to get a history about the symptoms, it's very often we are not able to tell the difference between damage or if there's a relapse. We try to get to know the patient very well. That's what I do so that I can identify if there's a true difference in symptoms. Recurrent infections are common and may mimic GPA. So when there's a lot of damage to the nose, you're more likely to get infections. The bacteria have a better access. And those symptoms are the same. So is this an infection or is this a relapse affecting the nose? That's a frequent question that we get. So local care is essential to try to prevent those infections in the nose. And some people will eventually need sinus surgery, hopefully not many, and timing may be an issue when we're trying to distinguish whether the disease is active or not. When is the best time to do surgery that we're going to do less harm? So those are very difficult questions that we're trying to obtain. These are examples of palpable purpura in leukocytoclastic vasculitis, which means it's a small vessel vasculitis of the skin that is frequently seen in GPA and MPA. So these are the kind of things we're looking at in the physical exam. In terms of laboratory tests in our process of making this diagnosis, they're very non-specific, most of the laboratory tests. We do get a complete blood cell count, because frequently there's anemia, high platelets. They're common at times when there's a lot of inflammation. The sedimentation rate and the C-reactive protein can be elevated at times of activity. The renal function is very extremely important because at that point in time when we first meet someone and we make a diagnosis of GPA or MPA, knowing that the kidneys are frequently affected, we need to find out as soon as possible whether the function of the kidney has been affected, and there's an urgency on start treatment immediately. So we look at the creatinine and the GFR. I'll talk a little bit about the ANCA test and how is that helpful to make the diagnosis. And we look at the urine sediment analysis. That's every time when we ask, can you get me a sample of your urine, and step out of the room and go to the microscope, because the urine sediment analysis is the first step to try to identify that the kidneys have been affected. And if we do that, we might be able to initiate treatment much sooner. This is what we're looking at when we step out of the room. So this is a vision under the microscope. And here, this is what we call a cast. It's a collection of cells, in this case, and the cells are stained here by a special stain that we use. And all the cells here are red blood cells. So this is abnormal, and it means that the kidneys have been affected with inflammation and there's some degree of damage. When we see this, we want to act very quickly. We want to find out what's the kidney function and initiate treatment as soon as possible. So this is one of the markers that we're looking for, that the kidneys have been affected in GPA or MPA. The ANCA test is an antibody that we check in the blood because they're commonly seen on these two diseases. Up to 90% of the patients can have a positive in GPA and up to 80 to 90% in MPA. They look a little bit different between these two diseases. For everybody who has a positive ANCA, 80% of them in GPA are of this type. It's called cytoplasmic ANCA, which is the appearance of what they look like under the microscope. And they're targeting a protein called proteinase 3, PR3. That's the antigen. So when you have this combination of positivity, it supports and helps us giving clue to make this diagnosis. And in MPA, 80% is a different kind of ANCA. It's called a perinuclear. It's also the appearance. And most of the time, this type of ANCA is targeting a protein called myeloperoxidase, which we call MPO ANCA, also giving us clues to make the diagnosis. It's not 100%, not everybody will have this test positive, so it doesn't rule it out, that you have GPA or MPA if the test doesn't come back positive. Imaging in helping us making this diagnosis. This is an example of bleeding in the lungs, which is quite frequent in MPA. It usually gives a lot of symptoms. Most of the time is not so subtle. And this is an example of a nodule here, which is a granulomatous inflammation, and that's more specific for GPA. This is how the imaging helps us. And finally, the biopsy when possible or when necessary. It's not necessary to make the diagnosis. The modern way to look at GPA and MPA does not require that we have to have a biopsy showing the disease in every single person. And biopsy is not always accessible. When we think about biopsy, these are the most common organ systems that we can biopsy. If there's a mass or a nodule or cavities in GPA in the lungs or any other part of the body. In the kidney, when the urine sediment is suggestive of kidney involvement, we might need to do a biopsy if we're not so sure about the diagnosis. But if we are convinced enough, we sometimes, very often, we spare it from having a biopsy and we can make a diagnosis without it. Skin lesions can be a target for biopsy when necessary, and other organs when they present with mass lesions. These are organs that are less commonly affected, so we tend to biopsy always because it's very difficult to distinguish that from cancer, for example. If someone presents with a mass or a lump in the breast, we won't know for sure, and then we need to know that we are dealing with the correct diagnosis. That's part of GPA. And in terms of treatment, I'll talk about both because they are both approached the same way. The goals of treatment in our current era is a little bit different than it was in the 1970s. At that time, we were trying to make everybody survive. So the goal of treatment at that time was increased survival. The way we look at it today is, yes, we can increase survival. We induce disease remission. But very importantly, no less important, we want to keep people in remission. We want to reduce the risk of relapses, and we want to minimize the treatment toxicity. So not only we want everybody to live longer and survive the disease, we want it to have quality of life. So decrease the amount of times when the disease relapses and decrease the amount of times that there's problems with the medications. As a general rule, all patients with GPA should receive prednisone plus a second agent. Those are diseases that are never treated with prednisone alone. We cannot sustain remission with that alone. Therapy is usually determined by severity of the disease. So just because someone has a vasculitis with a specific name, it doesn't tell us what is the medication. It's not like a cake recipe. Different manifestations and different severity of disease may be treated differently on the same disease. So someone with GPA who is losing their kidney function very quickly might get a different kind of treatment as someone who has a normal kidney function. So severity is the most important factor. So we look at involvement of critical organ system, the severity of clinical manifestation, and the rate of change. So how fast is this disease getting worse? Over days, over periods of months, or years? How aggressive do we need to be treating immediately? And patient individual factors are not less important. So age, fertility issues, so very young patients who still wish to have children, we try to take that all into account when selecting a medication. And in terms of medication, we call it a staged therapy because, as Dr. Langford was mentioning, the first goal is to induce remission. But once remission is achieved, especially in GPA, there is a risk of relapse that's still there, but we want to keep that remission going. So that's called the maintenance treatment when we're trying to reduce the risk of relapses. So we usually used one of these 3 drugs depending on the severity of the disease and depending on what kind of organ system is involved. It can be either cyclophosphamide, rituximab, or methotrexate. These are common medications used for induction therapy, and they've been well studied. For maintenance treatment, once the cyclophosphamide is stopped, a less toxic agent started to maintain, which could be methotrexate, azathioprine, or sometimes mycophenolate mofetil, which is CellCept, and sometimes other medications for people who have side effects or have had multiple relapses. If the rituximab is used for induction therapy, that's a little bit tricky now in the decision about maintenance because the options are to just continue the rituximab on regular intervals or to change to either azathioprine or methotrexate. An ongoing study will still reveal more about that. There's a lack of data to confirm whether one way is better than the other. Initial therapy, so just to summarize, is one of these 3 drugs plus glucocorticoid or steroids, and the dose of steroids tapered over time, usually between 6 to 12 months, and if possible, all the way to 0. That's our first goal. Treatment with cyclophosphamide does prolong life, but with a very high risk. We know about the toxicities, so we have to adjust and know how to use this drug well. The toxicity includes and are not limited to infections, low blood cell counts, which is bone marrow suppression, can lead to development of cancers, inflammation and bleeding of the bladder, and infertility. So when is it really necessary? Do we still have a role to use cyclophosphamide? Sometimes we still do use that for clinical features that pose immediate threat to life or to the function of critical organs. A very high creatinine or loss of kidney function might make us choose cyclophosphamide. And even at that point in time, in some of this more severe disease, rituximab can be used most of the time. These are some of the examples of urgent situations or a very severe disease where we would select the use of cyclophosphamide, or rapid progressive kidney disease, bleeding the lungs, brain involvement, neuropathy that is severe, heart involvement, vasculitis of the bowels, and severe non-healing skin ulcers. And if we're using cyclophosphamide, we're careful about monitoring and decrease the risks. So we decrease the exposure to cyclophosphamide for no longer than 3 to 6 months, and by that we decrease the risk of long-term development of cancers. We can always try to use a less toxic agent, rituximab or methotrexate, and we keep looking for new effective and less toxic medications in research as they're ongoing. And no less important, by very close monitor. So blood cell counts, we tend to do it weekly when cyclophosphamide, so we can adjust the dose. We adjust the dose also if the kidney function gets worse over time. It does require very frequent laboratory monitoring, usually weekly. But if rituximab is performing so well as we hear all the time, why do we still need to search for better induction therapies? Despite the large number of patients that are achieving remission with standard therapy, we all know that relapses are still frequent. A very large number of patients still do have relapses. Not all patients achieve remission. With all the drugs we have, our remission rate is not 100%. Treatment toxicity, mainly from steroids, is still significant. So we're always looking for treatments with less toxicity. I'm going to skip that and talk a little bit about challenges of therapy. So Based on the disease characteristics, we have a great challenge on treating this disease, especially in GPA, because there's a wide range of clinical manifestations, a broad spectrum of severity. Patients with the same disease might need to be treated differently. So we have to really remember to individualize, make it very individual, the treatment choices. Frequent relapse is a very important challenge that we have because every time there's a relapse and we start induction therapy again, we start new medications or we make adjustments, we are increasing the risk of toxicity from medication. So we would like to try to avoid completely relapses, and how can we do that is by continuing looking in research for new medications. And unfortunately, a small group of patients do not reach remission, what we call refractory disease. Fortunately, it's a very small percentage, but we still have to find different options for this group of people. So points to consider just in conclusion of making a treatment decision. We always ask ourselves, is the disease active? Or are symptoms from another problem? Are we dealing with side effects, infections, other diseases? Remember the mimickers. We might be having nosebleeds for different reasons, but the symptoms might be the same. Is there loss of kidney function? We always remember that because we have to keep checking. And consider individual patient factors when making treatment decisions. We continue to monitor this disease over time. After induction therapy is given, we ask ourselves, has remission been achieved? That's a way of monitoring. We monitor for possible treatment toxicity. We monitor for symptoms and signs over time to identify possible relapses and to help making a distinction between permanent damage and disease activity. So we monitor continuously for life. We monitor response to treatment with labs, by asking about symptoms, by looking at the urine in the office. Sometimes a lung CAT scan is necessary, sometimes other imaging studies. So it depends on each person. The ANCA is helpful in making the diagnosis, but persistent ANCA or rising titers, if they're getting worse, if they obtained over time, we really don't know, not clearly established who are at risk of relapse or not because their ANCA titers are going up. So we should not at this point in time make treatment decision based on the ANCA change alone. So that's an important point. So we take everything into account. And additional very important factors that we look at treatment is trying to avoid problems such as osteoporosis and severe infections such as pneumocystis jirovecii. So we prophylax or we prevent this infection by using either Bactrim, pentamidine, or tovacone. These are medications that are available. And I think you'd like to open for questions because I don't want to take, this is the last slide. And thank you for your attention.
So if you have questions, we'd ask to just jot them down as far as and hold them up so we can read those and have Dr. Villaforte. Does anyone have their question written down? Okay.
To go get it.
Yes. Stay put.
Okay.
All right. Thank you. All right. Any other questions? All right. So how can GPA and MPA affect the heart, and what are the symptoms of that?
In many different ways. There are three main ways that we think about the heart when it can be affected. Tissue itself, the blood vessels, the coronaries, and the pericardium, which is the lining outside the heart. So when it affects the pericardium, it can cause what we call pericarditis, so an inflammation of that tissue. And it causes a lot of chest pain. Myocarditis is the muscle itself when the inflammation is located in the muscle. And the coronaries is when the inflammation affects the blood vessel, and it can lead to actually heart attacks when it affects the coronaries. So it depends on what structure of the heart is affected. There are different types of manifestations. But all parts of the heart can be affected in both disease.
Is anything known as far as about triggers for GPA and MPA, such as things like infections or cancers?
There's a lot of and there's been research on that in the past. There's a lot of ideas and concepts about infections triggering, especially relapses, especially staphylococcal infections. But because of the idea that is so common that the nose, the ears, and the throat are affected in GPA, there might be some kind of environmental factors such as a bacteria or virus or fungus that was inhaled or someone was exposed to in the environment and it went through the nose, because that's the way the disease usually starts. But these are all theories. There has never been a proven microorganism or bacteria that has been linked to the development of the disease.
Is there any evidence that people are born with GPA and MPA?
There's no specific genes that are known or established to be linked to the disease. So we believe that there's some kind of dysfunction of the immune system that people are prone to develop, but not necessarily were born like this. So they can be developed, especially because the age of onset is closer to 40 or higher.
One of the questions we had submitted in advance as far as was how long do people need to stay on treatment for?
Tricky question. If someone develops the disease for the first time and has never had a relapse, that's the most difficult time to answer this question, because we don't exactly know the risk, but some of the studies have shown in the long term, as we follow patients for more than 8-10 years, that the risk of relapse is high for everyone, but much higher probably on people who already have had relapses. If we look at the number of years in studies, in the beginning it was 18 months, and then the longer we studied and followed up to 8 years, the risk of relapse once we stop therapy starts to go up again. So for GPA, although we don't have a good exact answer, I tend to, and a lot of other vasculitis treating physicians, to keep for life if there has been at least one relapse.
Are maintenance medications always needed for GPA and MPA?
It depends on what situation the person is. If they have had a relapse, I would say yes. The risk is very high if we keep them off treatment. If someone has never had a relapse, again, like I said, the answer is difficult, but the risk is there. Even though we can't put a number, I believe the maintenance therapy is always needed for at least 2 years.
We've got a couple of questions about long-term side effects of medication. The first one was Imiran, or the other name is azathioprine.
I'll group them together. So azathioprine, methotrexate, and Cellcept are old medications. There's a lot of experience of its use in other diseases. So we kind of learn the dosages that have been safe over time. Some of these medications have been available for over 30 years. So at the doses that we use, we don't have significant concerns over time. And in some patients, like for instance rheumatoid arthritis, they will use those medications for life, and there has never been proven to have an increased risk of cancer associated with that at the doses that we use.
The other one was rituximab, long-term side effects.
That's not really known because we haven't had rituximab for that long. So if you think about 10 years, 15 years later, we haven't had this drug available for the use specific of our disease in vasculitis. I think that's why we don't know what's the best optimal dose and the optimal interval and how often to give the rituximab, so that we can balance any potential long-term side effects that are still unknown with putting the disease in remission. So I think there's a lot that is unknown in terms of long-term use of rituximab.
Can damaged organs repair themselves?
Depending on the organ, yes. So to give 2 separate examples, skin can repair very well, and nerves not so well. So nerves are more prone to damage without much repair, and skin usually tends to heal completely. It just depends on what part of the body.
Thyroid problems are fairly common for us as people, but is there any link with GPA and MPA?
There's been observed in some studies, especially with GPA, that low thyroid hypothyroidism has been more commonly associated as compared to what's expected to the general population. Think about it as an autoimmune disease most of the time, so someone with one autoimmune disease might be more prone to develop other autoimmune disease.
And then I'm going to just do the last questions. I know I have a few more here as far as to keep on time, and say we'll have some opportunities to discuss those as well later. This is a difficult one, but in terms of how can people do with this? You know, what does this mean over 10, 20, 30 years, and how is this changing over time as we're learning more about these illnesses?
In terms of treatment and quality of life.
Treatment and quality of life and outlook.
I think that's a great question because that's always our goal. I mean, I want to see everybody alive, but I want to see everybody well and with a good quality of life. But I think it has changed a lot. When you think about when cyclophosphamide was first used and started to be used, and at that time, people didn't know exactly how to use, what was the optimal dose for how long, and then after 2 to 4 years of using cyclophosphamide, they observed a significant amount of side effects and toxicities that were permanent, and there was also a mortality rate that was increased. As we learn how to better use the drugs over time, and we have observed that, we give a better quality of life. So knowing very well how to use the medications in terms of dosages, duration of treatment, how do we prevent complications from the medications is key, because that is how we're going to prevent certain toxicities from the medication. And over the years, that plays an important role and makes a huge difference on how well people feel.
All right, so again, thank you to Dr. Villaforte for a wonderful discussion.